Good morning, all. Today, our topic is fungal keratitis. You know that fungi are a group of microorganisms. They have rigid cell walls and distinct nucleus with multiple chromosomes containing both DNA and RNA. And fungal keratitis is more in tropical and developing countries and rare in temperate countries. And it's a major cause of visual loss in tropical countries and developing countries. And it can elicit a very severe inflammatory response, and corneal perforation is common, and outlook for vision is frequently very poor. Two main type of fungi causes keratitis are yeast, example Candida, filamentous fungi, example Fusarium aspergillus. And yeast are ovoid unicellular organism that reproduce by budding, and they are responsible for most cases of fungal keratitis in temperate climate. And filamentous fungi, they are multicellular and produce tubular projections known as hyphae, and most common pathogens in tropical climate, but and also they can see in cooler regions. And keratitis frequently follows an aggressive course when it's caused by filamentous fungi like Fusarium and Aspergillus. And pathophysiology, the infection which is start when the epithelial integrity is broken, either due to trauma or ocular surface disease. And then only the organism gain access into the tissue and then it proliferates. They can release proteolytic enzymes, fungal antigens, toxins into the cornea, and which causes necrosis and damage to its corneal architecture and thus compromising the eye integrity and function. Next is the predisposing factors, and the common ones are chronic ocular surface disease and long-term use of topical steroids, contact lens wear, systemic immunosuppression, and diabetes. Filamentary keratitis may be associated with the trauma, often invariably minor trauma involving plant matter or gardening or architectural tools. The injury with vegetative matter, most common cause is filamentary keratitis. First is Candida and filamentous keratitis. Its diagnosis is frequently delayed unless there is a high index of suspicion of fungal infection, and it's often mistaken as bacterial infection and like that. And clinical signs are not a definitive means of distinguishing bacterial and fungal corneal infection. Symptoms, gradual onset of pain, grittiness, photophobia, blurred vision, watery or mucopurulent discharge. And Candida keratitis may have yellow, white, densely suppurative infiltrate, which is typical for it. And this image is showing filamentous fungal keratitis, which has it's a grayish infiltrate with a filamentous or feathery edges. We can see here in this image. Filamentous keratitis, gray or yellow-white stromal infiltrate with the indistinct and fluffy margins. In this figure A, we can see image of filamentous keratitis with the fluffy edges. We can see a large epithelial defects and folds in Descemet's membrane also. We can see this image. And this image we can see satellite lesions. And initially this stromal infiltrate with the initial lesion can progress into a progressive infiltration with the satellite lesion. And next is feathery branch-like extension or a ring-shaped infiltrate we can see. In this image, we can see ring-shaped infiltrate here and hypopyon. This and rapid progression with necrosis and thinning of cornea can be occur, and penetration of an intact Descemet membrane may occur and lead to endophthalmitis without evident perforation. Epithelial defect is not invariable in and sometimes, but a small sometimes a very small defect can be present. Other features include anterior uveitis, hypopyon, endothelial plaque, raised IOP, scleritis, and sterile or infective endophthalmitis. Differential diagnosis includes bacterial, herpetic, and academical keratitis. Bacterial infection may sometimes present in subacute fashion, particularly when typical organisms are responsible. It's important to be aware of co-infection, including an additional fungal species also. Next is investigations.
Shilpa,
Samples for, sir.
Shilpa, go back to the clinical features slide.
Sir.
Yeah, this slide is very, very important on the description of the ulcer.
Sir.
Those fluffy margins, satellite lesions,
Sure.
hyperlectics, and the elevated lesion.
Sure.
Yeah, these things you should remember very well. Okay.
Sure.
Fungal ulcer.
Sure.
Yeah. This slide, next slide is very, very important because most of the times, of course, if you do KYH, it's okay. We have to mostly proceed on a clinical basis.
Sure.
So these are some of the specific features of fungal keratitis.
Sure.
Okay, go ahead.
Shilpa, in 90% of cases of fungal ulcer, they present with this typical description, what is described in the textbook. Usually 90% cases present when they come starting to you, they come with any of these features, definitely. So it is easy to differentiate between a fungal and bacterial. So you should be able to diagnose if you remember these features.
Okay, ma'am.
Okay.
Okay. Next, investigations. The investigation samples for laboratory investigation should be acquired before commencing antifungal therapy. And staining is with the potassium hydroxide preparation with the direct microscopic evaluation, which is a rapid diagnostic tool and it very sensitive. And Gram and Giemsa staining are both 50% sensitive. Other stains include periodic acid shift, cauliflower white, and methenamine, silver methenamine. Here we can see the image of Candida, microscopic image of Candida with the cauliflower white staining. Cauliflower white stain.
Here, actually, we used to do KVH and gram stain,
Sure.
but because of manpower and busy schedule, I think we are not doing it regularly. But as a postgraduate, whenever I also, particularly if you suspect, no, you must do KVH.
Okay,
So, in our basic lab,
sure.
you make sure that KVH is available. And I think if possible, you can do gram stain also.
Okay, sir.
The lab technician is there.
Sir.
That is your responsibility.
Sure.
Once
Sir,
you
all
do
the cases of ulcer we are doing, sir, KOH.
KVH, okay, very good.
Yeah, KOH, I showed them also few cases. Filaments
Yes.
I have showed
Yes,
them.
sir.
They are seeing in my OPD, sir.
Okay, very good, very good.
Yeah, gram stain, I think we have to buy those stains.
Yeah.
Then we
Because
can.
that fellow full-time technician is there, no? So we can do gram stain also. But KVH is a must.
Sure. Next is culture. Corneous scrapes should be plated on sugar or dextrose agar, and most fungi will show growth on blood agar or enrichment media. But we have to get effective scrape from the ulcer base. For the culture and sensitivity testing for antifungal agents can be performed in reference laboratories. But relevance of this result to clinical effectiveness is uncertain. If applicable, contact lenses and contact lens and cases should be sent for culture. PCR analysis of specimen is rapid and highly sensitive in case of when we are using PCR. It's up to 90%. and it's the current investigation of choice. And while we are doing collecting specimen for PCR, you should careful about that calcium containing swabs can inhibit polymerase activity. Next is corneal biopsy is indicated in suspected fungal keratitis in the absence of clinical improvement after 3 to 4 days, and if no growth developed from scrapings after a week. A 2 to 3 mm block should be taken, which is similar to scleral block during trabeculectomy, and filamentous fungi tend to proliferate just anterior to distal membrane, and deep stromal specimen may be required. And the excessive block is sent for culture and histopathological analysis. And the anterior chamber tap advocated in resistant cases with the endothelial exudate because organisms may penetrate the endothelium, so that we can take an anterior chamber tap. In confocal microscopy, frequently permits identification of organisms in vivo, but it's not widely available outside tertiary centers. Next is
when it comes to how do you take scrapings? Tell me, how do you take it?
sir, with
Corneal scrapings.
blade, sir, columns.
Yeah. So you must have that BP with handle and knife. I think it's 50 number blade, 50 number blade, or 11 number blade. So you must have those things in the work.
50 number sterile packed blade we should use and scrape the edges and base of the ulcer. Okay. Make the patient put paraffin drops, make the patient sit on the slit lamp and do the scraping and smear it over a slide. Okay.
Okay, ma'am.
So your examination table should have, the bin should have, that the instrument set should have BP handle, a 50 number blade, and the slide. Okay.
Okay, sir.
Right, sir, should be ready and particularly on our examination station. Okay.
Okay, sir.
Right.
Next is treatment. The improvement of fungal corneal ulcer, it's slow in comparison to bacterial infection, and general measures is like hospital admission should be considered for the patient who are not likely to comply or are unable to self-administer treatment, or it should be also considered for aggressive disease, particularly if involving an only eye. And discontinuation of contact lens wear is mandatory, and a clear plastic eye shield should be worn between eye drop installation if significant thinning or a perforation is present. Removal of the epithelium over the lesion enhance penetration of antifungal agents, and it may also be helpful to regularly remove mucus and necrotic tissue with a spatula. Topical antifungals should initially be given hourly for 48 hours and then reduced as science permit. And
Shilpa, go back to previous slide. Previous slide. Yeah. So read it again.
Removal of the epithelium over the lesion, which enhance penetration of antifungal agents and also helpful for removing mucus and necrotic tissue with a spatula also.
This is the very important part of the treatment. If there is a slough and debris is there, so is there. Not only for fungal ulcers, for any ulcer, corneal ulcer, to penetrate the drug, you have to take out that layer. Okay, epithelium you have to always debride every day, maybe every day. So then the drug will penetrate and you will be reducing the either bacterial load or fungal load. So this is one of your routine steps. Ulcer comes means you have to do the debridement of the epithelium.
Sure.
Okay, go ahead.
Candida infection is treated with amphotericin B 0.15% or econazole 1%. Alternatives include natamycin 5%, fluconazole 2%, clotrimazole 1%, and voriconazole 1% or 2%. Next, filamentous infection is treated with natamycin 5% or econazole 1%. Alternatives are amphotericin B, meconazole, voriconazole. And other drugs are also available. Next, broad spectrum antibiotic we have to add to address or prevent bacterial co-infection, and cycloplegia as for bacterial keratitis. Subconjunctival fluconazole may be used in severe cases. In systemic antifungal use, it's given in severe case and when lesions are near the limbus and for suspected endophthalmitis. Options are voriconazole, itraconazole, or fluconazole. Voriconazole is 400 milligram twice daily for 1 day, then 200 milligram twice daily. And itraconazole 200 milligram once daily reduced to 100 milligram once daily, and fluconazole is 200 milligram twice daily. Tetracyclines like doxycycline 100 milligram
Go
twice
back
daily.
to the previous slide. There's a systemic antifungal. You have one more ketoconazole. Did you add? Ketoconazole.
Okay, ma'am.
Ketoconazole is very, very important. Okay.
Okay, ma'am.
So generally we don't use voriconazole, itraconazole, fluconazole we use, but voriconazole and has lot of side effects. So we don't use it regularly.
Okay.
And to give fluconazole and ketoconazole is a commonly given drug.
Okay, ma'am.
So you add that in your presentation. That is 200 mg BD or 400 mg once daily until the ulcer heals.
Okay, ma'am.
And we have to do liver function tests and renal function tests before giving.
Okay, ma'am.
You should have done more work on classification of antifungal agents. Should have gone a little more elaborately on the antifungal agents.
Okay, ma'am. Okay, sir.
Antifungal agents and their mechanism of action. At the same time, on this first part also, regarding the strains of fungus also, you should have gone a little more elaborately.
Okay, sir. Doxycycline 100 milligram twice daily. We can given it for anticollagenous effect when there is a significant thinning. And then next we have next is about perforation. Small perforation in which infection is controlled, which can be managed with the bandage contact lens. And tissue glue is often adequate for a slightly larger distance. And a penetrating keratoplasty or corneal patch graft may be necessary for a larger perforations or in those where infection is extensive or inadequately controlled. Occlusive surface repair techniques may be appropriate in some circumstances, and like an eye with no visual, useful visual potential. Next, superficial keratectomy, effective to debulk the lesion. Therapeutic keratoplasty is considered when medical therapy is ineffective or following perforation. Anterior chamber washout with the intracameral antifungal injection is considered for unresponsive cases in which there is a stable corneal infiltrate but enlarging endothelial exudations. In that cases, we can see anterior chamber washout with the intracameral antifungal injection. Prognosis: severe visual loss in 26% to 63% of patients with fungal corneal ulcer, and 15 to 20% may need evisceration, and penetrating keratoplasty is required in 31 to 38% of cases. Next is microsporidial keratitis. Microsporidia is obligate intracellular single-celled parasites. Previously, it's thought to be a protozoa, but now reclassified as a fungi, and they rarely cause disease in immunocompetent and most common general infections by microsporidia is enteritis. The most common ocular manifestation is keratoconjunctivitis. This is microsporidian classification of microsporidia species according to clinical manifestation. Here we can see keratoconjunctivitis with respiratory genital tract infection. This encephalitis of Soven intestinalis, this microsporidia causes dissemination to ocular infection of cornea, ocular infection, this stromal keratitis, this species, hominin species causing stromal keratitis, and many of the patient species are causing both enteritis and ocular infection. Some are only causing ocular infection. Okay. Diagnosis, signs, bilateral chronic diffuse PEK, we can see, and unilateral slowly progressive deep stromal keratitis. But this is rarely seen in immunocompetent patients. It's seen in immunosuppressed patients like HIV, diabetes mellitus, like that. And sclerokeratitis and endophthalmitis are rare in this case. In this
What is
picture,
PEK?
sir, peripheral epithelial keratitis, sir. Peripheral, sir.
No, punctate epithelial keratitis.
Punctate epithelial keratitis. In these pictures, we can see punctate epithelial keratitis, diffuse punctate epithelial keratitis, and these pictures we can see deep stromal infiltrate. Deep stromal infiltrate is most probably is unilateral, slowly progressive, and chronic. The punctate epithelial keratitis is most commonly is bilateral. Biopsy shows characteristics spores and intracellular parasites. PCR of scrapping is relatively low sensitivity. Treatment. Medical therapy of epithelial disease is with the topical fumagillin, and stromal disease is treated with a combination of topical fumagillin and oral albendazole 400 milligram once daily for 2 weeks, repeated 2 weeks later with a second course. The patient should be closely monitored for hepatic toxicity. Long-term fumagillin treatment may be required and is difficult to eradicate the parasite in immunocompromised patients. Next is what is fumagillin, sir?
How do you treat microsporidial infection?
Sir, we are treating with fluconazole, sir.
Fluconazole.
Fluconazole. It is showing good response. So, or otherwise chlorhexidine, sir. Chlorhexidine. Chlorhexidine we have to mix and give to the patient. So it is difficult procedure. So I am using fluconazole. So previously used to give chlorhexidine, sir, but now fluconazole also showing good response, and it is available bottled. So that's why continuing fluconazole.
That is the problem with the fungal diseases. Drugs are not available.
Sure. Next is what is this fumagillin? It's an antibiotic and anti-angiogenic agent derived from Aspergillus fumigatus. Has been found to be effective against encephalitis, protozoan species, and enterocytozoan species of microsporidia. And while toxic in systemic administration, topical use has been shown to be well tolerated and effective in treating keratoconjunctivitis. Then topical fluoroquinolones like ciprofloxacin 0.3%, moxifloxacin, cagifloxacin, levofloxacin, and norfloxacin we can give as a monotherapy or in combination with the topical fumagillin and or systemic albendazole have been studied for treatment of microsporadic keratitis, and resolution occurred in 99% cases with the topical fluoroquinolone monotherapy. It's from AJO, and they shows a study in 2021 case report described a successful use of topical voriconazole and oral albendazole to treat a case of microsporadial stromal keratitis. And epithelial debridement has been found to be successful in current disease confirmed to the epithelium, and medical management may be long term, and recurrence can occur following treatment discontinuation. In case of severe corneal thinning and necrosis, penetrating keratoplasty may be the only reliable treatment method. Keratoplasty may be indicated, although recurrence of disease can occur in graft periphery, and cryotherapy to the residual tissue may reduce the risk of recurrence. That's it. Thank you.
Go back to the previous slides. Yes, how many cases have you seen fungal keratitis in OPD?
So, ma'am, more than 10 to 15 cases, ma'am. More than that, ma'am.
Okay. How many cases did you see the scrapings?
Scrapings, almost all cases.
You saw the scrapings under microscope?
Yes, ma'am.
Okay.
So you can identify non-IFS and filamentary fungal. This one you can differentiate. KYH.
Sir, pardon me, sir.
You can identify IFA and non-IFA fungi.
Yes,
The
sir.
KYH slide.
Okay, slide, sir. I can identify fungi, sir.
Yeah.
Hmm.
No, on the base of the slide, you can differentiate between the candida and the
Sir, filamentous and round. I can differentiate, sir.
yeah.
Okay, what is the role of cycloplegia in fungal ulcer?
To prevent synechia formation and pain relief, ma'am.
Okay. How pain relief?
We are relaxing ciliary muscles, so paralyzing, ma'am. So pain relief.
Okay. So now what is the standard if you see a fungal ulcer? What is your standard protocol treatment?
Natamycin, voriconazole, natamycin with voriconazole, or natamycin alone with doxycycline for this anticollagenase effect with topical joint combined with the topical antibiotics with one of the cycloplegics.
Tell me the prescription. Number one drug, what you will write. Number two,
number one, with antifungal, we have to first give antifungal like voriconazole along with the natamycin or voriconazole alone. Next, topical antibiotic to prevent bacterial co-infection, and cycloplegic, one of cycloplegic, and then doxycycline, sir, for anticollagenase effect.
And
See, you should not give antibiotic. If you're sure that it is fungal ulcer, you should never add antibiotic.
Okay, ma'am.
Okay. So what antibiotic will do? It will wash away this thing, your antifungal.
Okay, ma'am.
and it will dilute the dose also.
Okay, ma'am.
So if you are sure that it is fungal and you see fungal filaments on the slide, just give only antifungals.
Okay, ma'am.
Don't give all the cocktail treatment, antibiotic, antiviral, everything. Okay.
Okay, ma'am.
So it will complicate the picture, and finally the treatment outcome is not good if you give everything.
Okay, ma'am.
So one antifungal and one cycloplegic painkiller
Okay,
with
ma'am.
supportive treatment like vitamins.
Okay, ma'am.
Okay, and that is the only thing.
There is associated uveitis, you can add IOP lowering agents, something like a Dimax, or a local dorzolamide.
Okay.
Anyway, painkiller is there, vitamin C is there.
If there is hypopyon and thinning of the ulcer, then only give these anti-glaucoma drugs. If the chamber is filled with lot of hypopyon, there can be chances of raised intraocular pressure because of angle. There is lot of inflammation in the angle. So to prevent glaucoma, we can systemically. Otherwise, regularly for small ulcers, just which are only present on the cornea, no need to give the anti-glaucoma treatment.
Okay, ma'am.
Okay.
Okay.
Just to explain the patient what are all the care that is to be taken, which is very, very important. So what kind of care do you advise for a fungal ulcer patient?
When you add systemic antifungals, Hema,
When it is close to the limbus or when there is a lot of associated scleral inflammation and lot of hypopyon and the ulcer is extending almost more than 2/3 of the cornea, there is hypopyon, then we give antifungals. Otherwise, regularly we don't give antifungals. So what is the
most important thing is every day you call the fungal patient and do epithelial debridement. That's very, very
Sir,
important.
now the standard protocol is we should not do every day, sir, because it's going to cause corneal thinning and scarring. It's going to increase the scarring. So once in 3 days, depending on the plaque.
Depending on the plaque, yeah.
Suppose if there is no plaque, no need for debridement. Suppose if there is fungal plaque, then only give the debridement. Otherwise, not required.
Okay.
So what is the care that you want to explain to a fungal ulcer patient?
Yeah,
Shilpa.
ma'am, we should not wear contact lenses. Then you have to use black goggles for a short period.
Okay, why black goggles?
Prevent photophobia, ma'am.
Then? So today you do one thing. You see in my OPD, there are pamphlets for the eye care that is to be given to a fungal ulcer patient.
Okay, ma'am.
Okay, that also you add in the treatment.
Okay.
Okay, that is the most important thing. So patient should not rub the eye, keep fingers, and they rub with everything. So water should not enter the eye until the ulcer heals. No head bath. Okay.
Okay, ma'am.
Yeah.
And most important, they should not use any local medications. Like sometimes they put breast milk, they put the local Ayurvedic medicines and some plant extracts, all that they'll be using.
Okay,
So
ma'am.
you should tell them to stop immediately everything. And the local RMP doctors, they give usually steroids. So
Mhm.
check with the patient whether he is having any kind of those medications and tell them to stop all those medications which they are previously using and give only antifungal treatment.
That is very important. Most of the times they are with the steroid bottle. Very, very important. You have to check the patient's previous drugs. Okay.
Mhm.
Okay, in my OPD, I have that this thing. Just read once. Okay.
Okay, ma'am.
And fungal carnation treatment doesn't end with the medical treatment. In continuation, it has a lot of surgical remedies.
So if there is a perforation, we have to manage with glue with PCL. If it is a larger perforation, we have to do a patch graft. Still large therapeutic keratoplasty. Suppose in case the ulcer heals with it has a lot of scarring and patient has visual disability even after that. So to treat the visual disability, we have to do an optical penetrating keratoplasty after 6 months after the ulcer heals.
Okay.
Sometimes the patient can develop cataract because of the inflammation. So we may have to do a cataract surgery that can be planned after 6 months after the ulcer heals. Okay.
Okay, ma'am.
So there is a lot of astigmatism also. So we have to, why we have to wait for 6 months is the astigmatism becomes stabilized.
Okay,
So
ma'am.
then we have to plan the cataract surgery.
Okay, ma'am.
And about Hema madam, how about using C3R in active fungal cases? Why don't you?
Actually,
Why
we
don't
have
you?
done, Madhu has done one randomized control trial, sir, in Arvind
Yeah,
Eye Hospital,
yeah.
which has shown that the C3R is not uh,
It's equivocal.
is not working for fungal ulcer.
Why don't you? We also can do it here, no? Some 10
Yeah,
cases.
but this is costly, no, sir. We need funding from this
Yeah,
company.
no, no.
Otherwise, we can't do.
Only thing is you need this type of flavor, that's all, no?
Sir?
Only you need riboflavin only, no?
Yes, sir. Riboflavin.
Yeah,
And
yeah. I ask these upper people to give some riboflavin for this study.
okay,
If you start the study, I'll ask them to give.
okay, sir. Okay, sir.
It's a simple some 10 cases if you do the study, no?
Yeah, yes, sir.
We
They
also
have
can
done
produce.
20 cases, sir. Madhu has done 20 cases, I think.
Yeah,
10
yeah,
cases with C3R, 10 cases without C3R.
yeah. That we can do.
Yes, sir.
Just think of give that idea and
Okay,
plan for it. Plan for it.
okay, sir. Okay, sir. Sir, regarding uh, this side donation program, sir.
Yes, yes, yes.
So all the doctors we are conducting. So
Uh,
Hussein, everyone is here. Hussein.
I think Hussein is late and I think his
Okay.
father-in-law is serious. I think he's out of
Okay.
station. I think he's out of station. I think.
Okay. Sir, regarding that this thing, sir, we need one phone number
Oh,
so that people can call the for eye collection.
okay.
So because we don't have any eye collection center in Eluru,
Okay.
so I asked Ali Prasad Eye Bank, sir.
Oh,
So they are telling that they are collecting for Eluru also.
okay.
So can we keep that number, sir? Their number?
Yeah, if they want any help from Eluru, we can do, no?
Yes, sir.
All the way coming from Vijayawada. Instead of that, you
Mm.
can talk to them or talk to Arvind Rai and
Mm.
we can come to an understanding with them and train one person here, our place only. And we'll collect it and send it to them only. But those people
actually they have already trained people, sir.
okay, yeah.
So already they have 4 or 5 trained people are there. So they'll be around 4 to 5 hours radius. They'll be traveling and collecting the tissues, sir.
Okay. First, okay. As a first step, we'll give their number.
Yes, sir.
We'll display in our hospital.
Yeah. That's what actually I'm discussing with Dr. Arvind also, sir, yesterday.
Okay.
So we will put that number and the iBank, their iBank small logo, sir. Like one side SNC iBank, SNC logo.
Yeah.
The other side phone number with the iBank logo.
Okay.
Okay, so that is fine, sir.
Yeah, that's fine. Okay, because some service we are extending. No?
Yeah, yes. Okay, sir. Sir, regarding the TV and interview and all that. So మీరు కూడా జాయిన్ అవుతారా సార్ టీవీ ఇంటర్వ్యూలో?
జాయిన్ అవుతారండి. మీరు మాట్లాడతారా? ఎవరితో మాట్లాడారు?
అదే సరే, అంటే ఎవరెవరు ఉంటారు అనేది ఒకసారి మనం కన్ఫర్మ్ చేసుకుంటే we can talk to the టీవీ పీపుల్.
టీవీ పీపుల్ అంటే మనము ఎస్ఎస్సి తరఫున చేయొచ్చు, లేదా మన అసోసియేషన్ తరఫున. అసోసియేషన్ తరఫున అంటే ఇప్పుడు ఐఎంఏ విజయభాస్కర్ రెడ్డి ఐఎంఏ ఉన్నాడు, లయన్స్ లో ఉన్నాడు. అలాగే ఆశ్రమం నుంచి మనము కూర్చొని ఒకసారి చెప్తానండి. ఈయన ఉన్నారు కదా,
ఈ రోజు మీటింగ్ పెడదామన్నారు సార్. ఎల్ఓసి
ఫిజికల్ పెడదామండి, జూమ్ పెట్టనా?
అది ఫిజికల్ బెటర్ సార్, జూమ్ లో అందరూ రావట్లేదు.
సరే అయితే నేను ఫోన్ చేయిస్తానండి. రెస్పాన్స్ బాగుంటే ఫిజికల్ గా పెట్టిస్తానండి.
ఓకే సార్.
రెస్పాన్స్ బాగాలేకపోతే జూమ్ పెట్టిస్తాను.
దీని గురించి కూడా మనం డిస్కస్ చేద్దాం సార్. ఆగస్ట్ 28th రోడ్ షో అని ప్లాన్ చేస్తున్నాం సార్.
సరే.
ఎక్కడి నుంచి అంటే మన ఓల్డ్ బస్ స్టాండ్ నుంచి తర్వాత ఈ పవర్ స్టేషన్ దాకా. ఓకే సార్, మన స్టాఫ్ అందరూ కూడా పార్టిసిపేట్ చేయాలని చెప్పాను సార్. తర్వాత ఇంకా ఆశ్రమం వాళ్ళు ఎవరైనా జాయిన్ అవుతానంటే, తర్వాత విజయభాస్కర్ రెడ్డి గారు హాస్పిటల్ లో జాయిన్ అవుతానంటే వాళ్ళని కూడా
జాయిన్ అవుతామండి. చూద్దాం. అదే రేపు అయితే వాళ్ళ ఫిజికల్ మీటింగ్ జరిగితే ఇది డిస్కస్ చేద్దాము. ఇట్లా నాటికి ఆ ఎమ్మెల్యేలు పిలిస్తే కప్పుకుని బాగానే వస్తారు, వస్తారండి. అయితే వాళ్ళ మనోజ్ని అందరికి ఫోన్ చేయమని చెప్తానండి. అందరు కనుక ఫిజికల్ గా వచ్చేటట్టుంటే ఫిజికల్ మీటింగ్ పెడతాను. ఒకవేళ ఎక్కువ రెస్పాన్స్ లేదనుకుంటే జూమ్ మీటింగ్ పెడతానండి.
ఓకే సార్.
సరే.
ఓకే సార్, థ్యాంక్ యూ సార్. విల్ డిస్పర్స్ సార్.
జస్ట్ అదే శిల్ప
sir.
You have to be a little more elaborate. This is not enough for your examination question.
Okay,
you
sir.
have to be little more elaborate about the classification of
antifungals, sir.
Fungus itself.
Fungus, okay, sir.
The classification has to be little more elaborate.
Okay,
and
sir.
Antifungal drugs also.
Okay, sir.
What are the fungicidal drugs? What are the fungi?
Okay, sir. I will read up and make I will make few slides regarding that, sir.
Yeah.
Okay,
so
sir.
that also you have to elaborate little more.
Okay, sir. Okay, sir.
This is only for a practical approach, but that
okay, sir.
approach it is not sufficient.
Sir, this is from Kansky and AGO journal, sir.
Yeah, it's not sufficient.
Sir.
Go through this one. I focus also very good lecture is there.
Sir.
Yeah, and the same I focus. Dr. Savitri Sharma's. She's a microbiologist.
Sir.
Her lecture also is there.
Sir, I saw, sir, little I have seen it previously, little microbiology.
Yeah, sir. Make it little more elaborate because
okay, sir.
It's a theory question. And
sir.
Clinics also clinical exam. long case also.
Okay, sir.
Lot of discussion will go on.
Okay, sir.
Yeah.
Shilpa, I want you to take the pictures. There are a lot of fungal ulcer pictures, much
Sir.
better than what you're showing.
Yes, ma'am. This is from
If you
textbook,
ask me, I
ma'am.
can give you.
Okay, ma'am.
Shilpa, you start that grabbing.
Sir, yes, sir,
Yeah,
today.
if it is working, we'll get some more.
Sir, the pictures are not that clear, sir. That's a problem. I log into the app and I tried taking pictures using app. And by using app, that application, it's zoomed pictures, but it's not that clear, sir.
It is there with you now?
The pictures, sir.
Yeah, the hammer, ఇప్పుడు ఒక
Sir,
చిన్న tool
it's there in Arugashri OPD, sir. I kept my small
Yeah.
bag there. I have all these things there. Sir.
No, that one show it to all.
Sir, I will today. I will
We'll
show.
get, if it is useful, we'll get. It's only hardly it costs 100 rupees, 150 rupees.
Sir.
So we'll give it to all the doctors and ophthalmic assistants.
Sir.
So that's the hand,
Sir.
So immediately to communicate between us.
Okay, sir.
Yeah. You try first and sir.
Okay, sir. Okay, sir.
Tell us how it is.
Sir.
Okay.
Okay, sir.
Okay,
Thank you.
yeah, thank you. Okay, end the meeting. Thank you very much.